Everybody. Welcome, everybody. I'm back with Professor Denning. We spoke last time about his illustrious career, and now I'm really interested to understand what's next for Professor Denning, because I know he's doing some really interesting research. And can you sort of give me sort of highlights of what your thinking is nowadays?
Yeah. So in 2010, after we had set up the National Aspergillosis Centre, we did a relatively simple modelling exercise, which became more and more complicated over time, to say, well, how many patients are there with chronic pulmonary aspergillosis in the world? And we started with TB because we knew that this disease occurred after you'd had TB. And so we looked at how many patients in the world that had TB, how many went on to get CPA, and the number came out at 1.2 million. And I must say that I was completely astonished by that, having seen a very small number of patients. I mean, our first series that we published, which took me 10 years to collect when I was working at North Manchester before I moved to Wythenshawe, we had 18 patients. So we do all these calculations and there's 1.2 million. And you think, what's going on here? Why has nobody known about this before? Why is there a gap in this knowledge area? So what that meant was that I realized that while I might know, and my colleagues that I worked with might know about CPA, the rest of the world clearly didn't know about this disease because it just wasn't in the literature. So that prompted in my head and in talking to many others, a need to do a better job of educating other people about the disease. So we set up Life Worldwide, which is a online high quality educational portal for doctors and nurses and physios and pharmacists and so on. And my colleague Juan Luis Rodriguez Tudela, who I still work with, he translated into Spanish. So that's still going, and that was an educational area. But that wasn't enough because it wasn't advocacy. It wasn't telling people like the WHO that they needed to worry about this disease. Yeah. So we then also split that off into Gafi, the Global Action for Fungal Infections, and set that up in 2013 to try to make the case that fungal disease more broadly, including CPA, but not CPA alone, was being ignored. And I think it's taken some years, but last October, the WHO then did publish this fungal pathogen priority list, which was really as a result of nearly 10 years of engagement, which I and my colleagues have had with the WHO. And that engagement included, for example, getting the antifungals onto the essential medicines list of the WHO. So the essential medicines list is important because countries in Africa and Asia who are not in Europe and part of the EU look to those lists to say, well, what drugs should we be getting in for our population? And if they're on the list, then that puts it as much higher up something that something isn't on the list. And then in 2016, the WHO decided to run an essential diagnostics list as well. And they opened that in 2018. And we ran a meeting in Kampala and collected which tests we thought should be on that list and presented those. And those gradually got accepted. There was quite a rigorous process, actually, writing, like a 50-page report to get them onto that list. Same as with the drugs, actually. That was also a big sort of documentation piece, but we did that. And so now the test for Aspergillus, at least the antigen test and the IgG antibody test are on that essential diagnostic list of WHO. So that means, again, that low middle income countries should be providing these tests for their population, but they're not. Now, some of that is a lag time of getting it on the list and then it taking time for things to percolate through the system and for things to happen. And we've just completed, for example, a survey in Africa, 48 countries, over 99% of the African population. And if you look at which countries are doing Aspergillus antigen testing, there's only 2 that are really doing it properly, and that's Morocco and Tunisia. And then a couple of others that occasionally do it. But even South Africa isn't doing Aspergillus antigen testing. And if you look at Aspergillus antibody testing, the numbers are similarly low. Not very many countries are doing these tests. So there is still a lot of work to do to persuade countries, doctors, health ministers, and so on, that actually they need to focus on fungal disease.
So was the initial side effect of, so you said 1.5 million people may have CPA. Was that pointing at, like you said, okay, well, this is clearly underfunded? Is that the story that you sort of advocated?
Yes, it's partly an underfunding, but it's even worse than that. It's that people don't even know that the disease exists. So we have had to do a lot of work just to get this disease into medical consciousness. So we've written a lot of papers. It's in chapters in the textbooks.
Yeah.
We've trained people who go out into the world and look for this disease and are finding the disease. We've had visitors come to Manchester to learn about how to manage it and take it home again in terms of management. Lots of different parts of that. One country that's not really recognized it yet is the USA. There's not a single series of patients with CPA from the US. And I think that's because the respiratory community is not really interested in it. It's probably not very common over there. And there are other countries in the world where it's only starting to become recognized. China has really taken the disease on. I mean, for example, so I gave a talk in 2018 in China based on our guidelines that we'd issued from Europe with a group of experts. And it was a funny talk because all the text was in Chinese or in Mandarin, but I was speaking in English and being translated. And the room had 500 lung doctors there listening to it. And since that time, chronic pulmonary aspergillosis is diagnosed across China. It took some time, but they now have guidelines about it. They have the tests. They're treating patients with itraconazole, voriconazole. So the awareness is a big factor in trying to do that, and that requires educating and stimulating specialists to think about it. Otherwise, it's all just TB. We just got TB, and it's just treated as TB.
So do you believe that if you look at lower income countries, right, Nigeria, right, that the challenge there is only financial, or it is organizational? Like, it's a big country. Obviously, there will be a lot of people who are unwell. How like say Nigeria?
It's both of those things, but the financial piece is significant in a specific way. In that, in most African countries, patients have to pay for all of their tests and all their medicines. So there's basically nothing for free apart from vaccines or if you have HIV or TB or malaria. Those things are treated and covered, but almost everything else you have to pay for. So given that, the systems aren't there because the patients haven't had the money, the labs haven't offered the test, and so on. So overcoming that's quite hard, because if you educate the doctors and they ask for the test and the lab doesn't have it, then they can't make a diagnosis. If the lab offers the test, but you don't tell the doctors about it, nobody asks for the test, so you haven't got it. So you've got to do the lab and the clinical education in parallel to make a difference.
Is part of your work also itraconazole in the official way is quite expensive, but there is also the white label one, right? Are you? And I don't know the status of the other medications, but is that what you're also aiming at, what you're advocating for, lower prices for low-income countries?
Yes, mostly indirectly. We don't go to the country saying, you should have this medicine and it should only cost this much. What we've been trying to do is to stimulate enough usage of the medicine so that the price can come down. So when we first were talking about this with Nigeria, a daily cost of itraconazole was about £12. In Britain, it was about £3, right? And why was that? Was because there was a single distributor and very little usage. So there just wasn't the flow for them to be able to consider a reduction, and there was no competition, basically.
Right.
So what's really required is much greater volumes of usage and competition, and that will inevitably bring the price down. You could go to the country and say, put a price cap on it, but that isn't probably going to be as effective as actually increasing the number of patients needing it and competition, I think.
Yeah, price cap could kill the supply, right? So yes,
that's right. Yeah. Because then people say, well, I don't want to bother with it at all. That's the problem. Yeah.
Do you have any estimates how many people that you think have aspergillosis versus how many people get more or less the right treatment? Do we know that, or do we have any idea about that?
Right. So we've just finished a modeling exercise in India on patients with TB or aspergillosis or both. And every year in India, there's about 2 million people diagnosed with pulmonary TB and 500,000 who die. So that's 25% death rate, which is much higher than it would be in Britain, for example. Yeah. In Britain, the mortality from TB is under 10%. So then we said, well, how many have got a misdiagnosis of TB? So they are treated for TB, but they haven't got the disease and have actually got aspergillosis. How many get aspergillosis as they're finishing their TB treatment or just afterwards? And how many are cured of their TB and then come back later with aspergillosis, years later sometimes? And when you put all those numbers together, we think there's probably about 1.5 million people with CPA in India, just related to TB. And about every year, probably somewhere around 200,000 or 300,000 are misdiagnosed as having TB when they don't have TB. And then this is a little less secure, but when you look at the deaths, it's probably around 140,000. So maybe nearly a third of the deaths of TB are actually not TB, they're actually aspergillosis. The reason I'm not so sure about that is because there are no good series looking at younger patients with TB or CPA related to TB and what their survival or mortality is. Most of the series related to CPA survival are from Manchester, France, Italy, and so on, and Korea and Japan, and they're not basically 30 and 40-year-olds, which is the group of people that are getting TB and CPA in India. So there's a little uncertainty about that mortality figure, but it will be considerable. I just don't know whether it's the right number.
So really what you're trying to do, if I sort of make an abstraction, is like your career was in Manchester and Stanford and so forth in research and in clinical care, but I think now in your career you're more looking at scaling up on a global level, on a policy level. Would that be a good way of putting it?
That's absolutely right, yes. And so although I've focused on this discussion about CPA and things, we're also interested in histoplasmosis and cryptococcal meningitis and patients with recurrent thrush, women with recurrent thrush, children with tinea capitis, hair infections, predominantly in Africa and so on, because to make the case for the drugs and better diagnostics, you've got to be much broader in your approach than just saying we've just got to manage just ABPA or just got to manage histoplasmosis or something.
Yeah.
And we have now published over 80 papers from individual countries on how many fungal infections they probably have. They're all estimates. And with estimates, they're all going to be wrong.
Yeah, right.
You just hope they're just only a little bit wrong and not wildly wrong. But for each of those papers, that becomes essentially an argument for the government to focus and invest in that topic area. Because if you go to a government minister and say, you've got to do something about fungal disease, their first question is, well, how big a problem is it? That's right. Inevitably their first question. And if you can't answer that question, then you're stuck. Yeah. So we've tried to do these burden of disease papers, and as I say, and the biggest one and most recent one out is India. We've got Sudan is nearly finished, and hoping that Panama is going to come out soon, and so on. We've done some quite small countries and some quite big countries. But yes, that's it's a policy change that we're interested in. That's exactly right.
What's the next big project that you're looking at?
Right. So what we're going to do with Gafi is we're going to shift the emphasis to demonstrating benefit in a population, not a whole country necessarily, but a population of patients or a region related to implementing diagnostics and treatment. So we've done this in Guatemala. We've using a single laboratory, which produces a rapid turnaround time of tests for patients with HIV, and educating the doctors around the country, sending the tests in, very rapid turnaround time for the results. We've shown a reduction in mortality of 7% over 2 years, which is a huge change.
Right.
Absolutely fantastic piece of work. And my colleagues, Juan Luis Rodriguez Tudela and Ana Alastrui, and also Eduardo Arathun, who's in Guatemala City, have done all that work. I conceived of the idea, but they have delivered it. And so the question is, can we move that and take that idea and do it somewhere else? And can we do it for other diseases? Could we do it for aspergillosis, for example? There's a fantastic group in Hanoi, which I think could do that in northern Vietnam, where they've got a lot of TB. Could we do it for very difficult skin infections? Could we do it for critical care and patients with cancer in low-income countries instead of high-income countries? So I think that's what we would like to do, is to take what we've done with Guatemala and adapt it and sort of internalize it in a different place and demonstrate benefit on a sort of a population basis of some sort.
That's absolutely fascinating. And indeed, that is what we said. That's like, is delivering change at scale. It's quite amazing, the impact you can have. So I'd like to thank you again, for taking the time to talk to us. It's really interesting how you scale this up, and I'll be following it with a great interest. And I know the people who watch, everything you do is available on your website. The papers are published, so if people are interested, they can follow it in great detail. So thank you very much, Professor Denning.
Thank you very much for the opportunity.